Dr. Davis is an associate professor at TU. She took her doctoral training at the University of Arkansas in an internship at the Medical University of South Carolina and postdoctoral fellowship at the National Crime Victims Research and Treatment Center in Charleston. Her program here is focused on trauma and the nightmares related to that. So we're really glad that you can be with us, Dr. Davis, and we will turn it over to you.
All right, thank you. I want to thank Irv so much for asking me to be here today, especially on Veterans Day. This has become an area increasingly near and dear to my heart. My father is a Vietnam veteran, and I grew up watching him struggle through much of my life. And my professional interests have increasingly turned toward the area of veterans issues, and so I'm very excited to be talking to you about this today. What I want to do is talk to you a little bit about the problem of sleep and nightmares in veterans, and to tell you about a treatment program that we have currently going on at the University of Tulsa. I have some data to present to you to show what it is that we're finding with our treatment approach, and then talk to you about where we're going a little bit in the future. In the back of the room, I have two handouts. I have one, it's called a clinician handout, and basically tells about the study that we're doing at TU right now, and it gives sort of the background of it and some of the criteria for the study, in case you know of anybody who might be interested. We also have flyers for people if you want to hand them out to people who might be interested in getting signed up with our treatment study. So I have on here myself and two of my students who have been very, very involved in the trial that we just ended, which was veteran-focused. We do have an ongoing treatment study that veterans can be involved in, but it's open to a more general population. I put on here a slide a little bit about me. I didn't know that I'd get such a great introduction from Irv. I am from New York originally, not that part, the good part of New York, upstate New York. Everybody assumes if you say New York, you mean the city, but I'm from the good part. And I did go to school at the University of Arkansas. The reason that I went there was because at the time, this was one of the only places in the country that you could do trauma-specific studies at a graduate student level. This was 13 years after they introduced the concept of post-traumatic stress disorder into the diagnostic manual, and so trauma studies wasn't a huge area, and certainly not at that level. I then went to the Medical University of South Carolina, as Irv said, and then did a two-year fellowship at the National Crime Victims Research and Treatment Center, and then ended up at TU as a professor. And I've been here since 2001. So I've been studying, treating, reading about, talking about trauma for a very long time now. My favorite television show is Special Victims Unit, Law and Order. So even in my off time, I'm all about trauma. So what I wanted to do today is just talk a little bit about trauma in general and the effects that you'll see from people who experience traumatic events. Talk a little bit about nightmares and sleep disturbances in particular, introduce you to the treatment approach that we have developed over time, talk to you about what we're finding in terms of empirical support, and then where we're going with this study. So I want you to imagine first your sleep being disrupted by this scenario night after night for over 40 years. I'm in a foxhole, tired, haven't slept much in 3 or 4 days, and the night heat is devastating and miserable. I'm trying to shave out of my steel pot and get ready for our operation. Suddenly, mortar rounds begin to fall from the sky. Marines around me were dropping as shrapnel was ripping them apart, and I'm frozen in place, unable to move. One dead Marine lay just feet from my position as smoke leaks from his body where his head should be. I sight my target, but I can't seem to pull the trigger. My heart is racing, and the harder I try to pull the trigger, it just won't drop. Instantly, I'm about even with the muzzle of a gun when the blast hits me. This is a compilation of nightmares from several different people. We didn't want to include just one person's story in case it could be recognizable. But what we're seeing is people suffering from these kind of scenarios night after night after night. Most of the people that we see in the veteran study have had nightmares multiple times per week for over 40 years. In our civilian studies, it's multiple times per week, 16 to 18 years on average. So these are chronic problems. And for a lot of people, and I'll get into this a little bit further in a couple of minutes, but for a lot of people, it really is scenarios that seem to be very close to what they actually went through. And so they are being re-traumatized night after night after night. And it has a tremendous impact on people's ability to function during the day when that's what your night is like. So I wanted to give you just that introduction. Just in terms of what are we talking about when I'm talking about trauma, I'm talking about when people experience, witness, or are confronted with an event or events that involve actual threat and death, serious injury, or threat to the integrity of self and others. And the response involves fear, helplessness, or horror. This is the standard definition that is used by the Diagnostic and Statistical Manual of Mental Disorders that psychiatrists and psychologists use to diagnose people with post-traumatic stress disorder. You can tell from this description that being in combat, being in war, in and of itself may not be considered a traumatic event if you haven't experienced other things. Also, you can see from this that it may not be just what you've experienced in war that is problematic. A lot of the veterans that we see in our studies have combat experience, have combat trauma, but also have a history of other things that they've gone through, child abuse, physical abuse, sexual assault. And we know that the more things that you experience, the greater impact it's going to have or it can have on you. And so when we're talking about veterans and we're talking about their life histories, we really are talking about potentially a pretty broad range of traumatic experiences that they've had. So these are the types of things that we hear about from veterans coming in. So witnessing death or injury, experience physical assault, experiencing sexual assault, and this may be in the military, this may have been in childhood, this may have been at some other time in their life. Motor vehicle accidents, experiencing natural disasters, and of course, combat. Now, not everybody who experiences a traumatic event is going to have significant problems. There is a range of potential responses. Some people will experience an initial transient reaction and then seem to do okay. There are people who may experience more acute stress responses, and then there's a small minority who will go on to experience chronic post-traumatic stress disorder as well as other difficulties. So it's important to understand that while most people who go through a traumatic event will experience some reaction from that, it's only a small minority that will go on to experience chronic problems. Of course, that differs significantly, the percentages of that, depending on the type of trauma that you've gone through and other issues that we'll talk about. So in addition to post-traumatic stress disorder, are there other things that you all may have heard about that people who are coming back from war or have experienced some other type of traumatic event may experience?
Divorce.
Divorce? Mm-hmm. Absolutely.
Becoming a father again.
Becoming a father again? Mm-hmm. Any other problems?
You mentioned, but I think increasingly we're recognizing the issue of sexual trauma aside from anything that even happens outside the United States, the military, the exposure, especially for women. Mm-hmm. Some of the news stories highlight that as an issue, so you don't even have to be out of the United States as a service member.
Absolutely. Absolutely. Those problems are tremendous in the military. I put some up here. Any one of these, and usually lots of these, people can experience when coming back. So everything from being exhausted, using substances to try to deal with everything else that may be going on as a way of coping with or avoiding dealing with issues. Irritability, change in boundaries, so not knowing really where your stuff ends and somebody else's stuff begins. Isolating oneself. I'm working with somebody right now who lives out in the country on the end of a very isolated place, the end of a dead end. And he says, I know when people are coming, and I know long before they get here that they're coming. And that's the way he wants it. It's very important to him that he is able to have some control over his surroundings, and that's one way he's done it, is by living out far enough away that if you have to really be intentional about going to see him, if you want to see him. Change in spirituality is pretty huge as well. There are some people who become much more religious and some people who become much less religious after experiencing a traumatic event. It changes the way that you perceive everything, yourself, other people, the world, God. It changes everything. And each of these is going to have an impact on how people are functioning. And then you put all of this together, and for some people, this is a very scary picture. One of the things that you hear most about is post-traumatic stress disorder. These are the criteria for PTSD. So you have re-experiencing, so that's where nightmares come in, where you're re-experiencing the event at night. There's re-experiencing during the day in terms of unwanted thoughts, intrusive memories. Some people have flashbacks where they actually feel like they're in the situation again. I worked with one gentleman who lived, it was out in the country, and he had this very beautiful backyard that was wooded that he could never go to, because the second he stepped from his sort of landscaped backyard into the wooded part, all of a sudden he was in Vietnam, and he would have a flashback, and everything that he saw was Vietnam, and what he smelled was Vietnam, and what he heard. So it was like he was there again. So he had this beautiful place that he really couldn't enjoy. Avoidance and numbing. Avoidance refers to behavioral avoidance of people, places, and things that remind you of traumatic events. So that may be not driving in a certain place if you had an accident there, or if it reminds you of the trauma in some way. That can be avoiding other veterans. If you don't want to talk about it, you don't want to hear stories about it. Can be avoiding Veterans Administration. It can be, the numbing part refers to just not having strong feelings anymore, having a very restricted range, so you're just not as happy as you used to be. Hyperarousal refers to that sense of being hypervigilant, being on guard, constantly looking over your shoulder, being aware of your surroundings. I have to be very careful when I do treatment. Usually as a clinician, you're taught that you sit between the client and the door, so if anything goes wrong, that you can get out. But with trauma victims, it's very different. If you sit between a trauma victim and the door, it makes them very, very uncomfortable. They feel kind of trapped and like they have nowhere to go. And so even small things like that, you have to really take into consideration how that's going to impact people. These symptoms have to last for longer than a month and cause clinically significant distress. If you look at what people go through, trauma, unfortunately, is not a rare occurrence in our society. So if these are the percentages of people who would experience a given traumatic event in their lifetime, and that's in the blue, so you can see the percentages. And then you see the percentages in yellow or gold of the people who have had those experiences who have post-traumatic stress disorder. So this is not evenly distributed, for sure. So people who have combat, molestation, child abuse, and rape, much more likely to have post-traumatic stress disorder than somebody who has witnessed an accident, been in an accident, been under some sort of other threat. Natural disaster is even lower. And then more than 25% of people who have experienced a traumatic event have experienced multiple events. And so again, the more things that happen to you, the greater the distress that you're likely to feel. As we've alluded to, not everybody who experiences a trauma has PTSD. There are some specific factors that we've been able to identify that may increase the chance for somebody to meet criteria for PTSD, and those are some of them. There are things that may happen before the traumatic event, just if you have psychiatric problems beforehand, if you've had traumatic events beforehand. Women, much more likely to get post-traumatic stress disorder after traumatic event. In terms of the trauma, it depends on the type, it depends on how severe it was. The peritraumatic reactions, if you responded with fear, helplessness, or horror, if you dissociated or blanked out during part of it, you may be at greater risk for PTSD. If you have cognitions of losing control, being out of control, not being able to control your environment, those can also have an impact. And then post-trauma, one of the biggest ones that comes out is social support. If you don't have an established social network that you can rely on and is there for you, then you will be at greater risk of PTSD. Yes, sir?
And it seems to me with some veterans especially who are anxious and frightened to be out away from home or even out in a crowd, the opportunity for social support disappears too. So
Absolutely.
It's a compounding issue there.
Absolutely. Yes. So what people frequently want to do is isolate from anybody and everybody, which doesn't allow them to have those positive experiences of social support, even if the network is there. So there's a lot that plays against that. Absolutely. And even somebody for whom none of this is a factor can still get post-traumatic stress disorder. So we're still learning a lot about what is going to increase somebody's risk, but anybody is at risk for PTSD. So in the late 1980s, a researcher by the name of Richard Ross said that really nightmares and sleep disturbances seem to be the hallmarks of post-traumatic stress disorder. And he said they are responsible for the maintenance of post-traumatic stress disorder as well as its development. So people who have sleep and nightmare problems immediately after the traumatic event are much more likely to experience long-term, ongoing chronic post-traumatic stress disorder. So this seems to be key for a lot of people. Most people who experience a trauma will have a transient time during which they have problems with sleep and nightmares. The vast majority of people do seem to recover and get over that and move on. It is actually a minority of people for whom that will be an issue over time, but it is one of the most chronic symptoms, and we'll talk about that a little bit. So, but first I want to just make some distinctions in between the types of problematic things that can happen at night. Some people may experience night terrors. So this is something that happens in the early part of the sleep cycle. Has anybody ever seen somebody who's had a night terror? Yes, okay. I have 3 boys, and one of them, my middle child, has night terrors. Not so much anymore, but he will awaken, or he will start screaming and yelling in the middle of the night, and I'll run up to his room, and he's sitting up in bed, and his eyes are huge, and he's yelling, and it looks like he's staring at the devil himself. I mean, it's absolutely terrifying. And they're very difficult to arouse. They usually don't wake up. And if they do, they're kind of very disoriented, and they don't fully orient. They go back to sleep. The next day, they don't even remember having them. You, as the significant other or the parent, can't go back to sleep because it's absolutely, you've been terrified now. So that is one thing that can happen that is often mistaken for a nightmare, but is considered a very separate kind of issue. But definitely, veterans can have night terrors. There are anxiety dreams, so these are the dreams that we all have about, showing up for a talk that you're supposed to do and sleeping through your alarm. Some of you you may have had some of those. Self-disclosure, yes. And so these are the ones that we all have. They're anxiety-provoking, they're a bit distressing, they usually do not wake us up. That's why they're dreams and not nightmares. So this is an example of, it's labeled a dog nightmare, and he says, oh no, I'm standing in the middle of downtown with clothes on. But actually, this is a dog anxiety dream because he's still sleeping. So we need to be careful about our cartoons. So REM nightmares, these are the nightmares that most of us have every now and again, where we dream about something very disturbing, and it's disturbing enough that it wakes us up. That would be considered a REM nightmare. REM nightmares tend to happen towards the end of your sleep cycle, so just before you're going to get up anyways, so you've had a full night's sleep. They can be related to stress, they can be related to medications, and they can be related to physical illness. So those are the ones that we'll all have now and again.
What does REM stand for?
I'm sorry, rapid eye movement sleep. So that's the sleep cycle in which you would have nightmares. They tend to happen just in that time period. And then you have trauma nightmares. So these are ones that may not necessarily start after a traumatic event. So you may have had nightmares beforehand, but if you did, then they become much worse after a traumatic event, or they change in terms of content, frequency, severity. But a lot of people don't have a problem with nightmares until after experiencing a trauma. So yes?
Do you see much insomnia with PTSD?
Absolutely. Absolutely. It's huge. Yep. And we'll go throughout, I have some prevalence rates for what veterans are reporting in terms of specific sleep problems. Insomnia comes in the PTSD symptom cluster for hypervigilance. So that's, the feeling on guard, constantly looking over your shoulder, and it's also can't get to sleep and can't stay asleep. So those two are very significant, absolutely. In terms of prevalence of nightmares, just in the general population, it's about 1% to 8% of people who would report frequent nightmares, which we would consider at least one per week. In general, they tend to decrease with age, so they peak like 6 to 9 years of age, and then they tend to start decreasing, although there's some evidence that there may be an additional bump in mid-adolescence, particularly for girls, and we think that that's probably related to experiences of sexual assault, unfortunately. But when you're talking about trauma victims, 50 to 88% of trauma victims will experience a problem with frequent nightmares, and the higher rates refer to those people who have post-traumatic stress disorder. Among Vietnam veterans, 53 to 88% report chronic trauma-related nightmares, and so that is taking people who, years and years after the war, who are still reporting that they have chronic nightmares. They can persist for decades, and it, like I said before, it is one of the ones that tends to last the longest.
Do we have any data on that, of the POWs?
I'm not sure if they've done that, if they've broken it down to look specifically at POWs. I can look for that to see if there's...
Most POWs were flyers.
Mm-hmm.
Did experience the combat on the ground.
Mm-hmm. Yep, so I can look for that to see but I haven't seen anything that's broken it down that specifically. This is, the nightmares and the sleep problems is a relatively new area. Like I said, in the late 80s, it was identified as being a really significant part of this, and since then, the research has been growing, but there's still very little that we know about it. When people look for post-trauma problems, they've looked at sort of PTSD in general, not at the specific symptoms. So there's a lot, unfortunately, that we don't know. For OEF, OIF veterans, 70% are reporting persistent sleep problems. 56% said their sleep was bad or very bad in terms of just overall quality. 40% say that they have delayed sleep onset, so they're having trouble getting to sleep at night. Almost 60% are waking up in the middle of the night at least 3 times. Oftentimes this is because of nightmares. And then 57% are reporting having nightmares. We also know that for some people, they can come back, dive right into work, dive into volunteer work, go back to being with their families, and they can do fairly well for a little bit of time. And then it's later when things aren't quite so busy that people start having problems again. So we expect these numbers to fluctuate. So what do we know about trauma-related nightmares? They are accompanied by arousal and body movement, which is unusual. If you think about what would happen if you were sleeping and you had all these scenarios going through your head, traumatic or otherwise, nightmares or even good dreams, and you were acting them out, that might be problematic? Yes. Some of the dreams I've had, that would be problematic. So what our body does is it basically, when we are in rapid eye movement sleep, we experience what is called muscle atonia. So our muscles become basically paralyzed so that we don't act out the stories going through our heads. That doesn't seem to be in place when it comes to trauma-related nightmares. People experience a lot of arousal and body movement. So there are mechanisms that are not working the way that they should. These usually occur in rapid eye movement sleep or stage 2 sleep, and they occur very early in the sleep cycle. So usually the first third of the sleep cycle is when this is going to happen. This is really problematic, and I'll explain why. So this is what our sleep looks like as we go through the night. So we transition through stage 1, 2, 3, and 4, 3 and 4 being that very deep sleep. And then we come back out and we experience REM sleep. So the dark blue lines are the rapid eye movement sleep. What you see is that we go through about 4 or 5 cycles usually per night if we sleep 7 to 8 hours. And the REM sleep, it gets increasingly longer as we go through the night, okay? What happens during REM sleep, we think, is that a lot of your basic functions are being kicked off. So your body's secreting hormones that, growth hormones, it's secreting hormones that tell you that you're full, that you're not hungry. It is secreting lots of different things. And also during this time, there's memory consolidation going on, particularly for emotional memories. And so usually for most of us, things that happen during our day, our mind replays some of that during night and makes connections with things that have happened to us in the past. And so that's how the memory consolidation works. So if you are somebody who is experiencing significant trauma and you are waking up within the first third of the night, so maybe about here, this is all the REM sleep that you're getting, which means that a lot of the restorative functions of sleep are not happening, okay? So you're missing out on all of this. This may also point to why there may be problems with memories and flashbacks and intrusions, and why people have such a hard time sort of making the traumatic event that they've been through kind of fit with everything else in their lives. For a lot of people, it doesn't. And that's why the mind keeps replaying it over and over and over again, because we don't have a way of really understanding it. This may be part of the problem. This is why they think that REM sleep may be such a big issue. So if you're not getting it, then that memory consolidation does not have a chance to work. So if you have somebody who's waking up here and that's all the REM sleep that they're getting, even if they're trying to make up for sleep by taking a nap the next day, they don't start here, they start back here. And so they're probably going to take an hour and a half maybe of sleep. So each of these is about 90 minutes. And they may just get this again, maybe just a little bit of this. Okay? So overall, they are not getting the restorative sleep that they need. And that's going to have a major impact on your functioning. Anybody in here been sleep deprived ever?
No.
No, right?
Anybody have children? Or dogs?
Children, dogs, absolutely. Life. Okay. So these are also individuals who not only are they not getting the restorative functions of sleep, not only are they not experiencing the benefits of memory consolidation, they're sleep deprived. So if you're only getting a couple hours of sleep per night, that is going to have a major impact on you. There have been studies now that show that if you miss just 1 or 2 hours of sleep over a couple of nights per week, you're basically functioning as if you had a blood alcohol level of like 0.05. If you are like my college students who stay up for a 24-hour period to cram for an exam, the worst thing you could possibly do, the next day after that 24-hour period, you're basically functioning as if you have a blood alcohol level of 0.10, over the legal limit. Okay? So these are chronically sleep-deprived individuals. Just imagine what that's doing to their functioning during the day. It's absolutely terrible. Okay. So we know that for a lot of people, nightmares and sleep problems are transient. They struggle with it a little bit, but then their system seems to kick into place and they seem to do well. For a small minority, they're going to have problems, especially in the presence of post-traumatic stress disorder. Nightmares are recurrent, which means that they replay over and over and over again. Even if it's not the same specific thing they're dreaming about, oftentimes it'll be very similar. It'll be the same theme over and over again. They're persistent. They last a very long period of time, oftentimes. So if you're still having nightmares after about 1 month from the trauma, the chances of them being chronic is pretty good. In terms of content, we've actually looked at this in our studies. When we looked at civilians, we found that 20% are reporting replicative nightmares, which means that the nightmare is almost exact replay of their trauma, whether that's a rape, whether that's a child abuse incident, or that's some other type of traumatic event. 50% report that it's similar, so it's the same basic thing happens, but the people are different, or maybe in a different place. One of the first people that I ever treated when I came to Tulsa was a woman who had a very horrific experience of rape. It was really very terrible, not that they all aren't, but involved significant torture. And so she dreamt about this probably 5 nights a week. And I saw her, I think it was 15 years after the event. So, pretty much every night of the week. She became a mom, and her nightmares started to change. And instead of her being in the chair being tortured, it was actually her daughter. So it did change, but it got even more horrific for her rather than less horrific. And then 30% report that it doesn't seem to have anything to do with the traumatic event at all. But if you think about it, or if you have them talk about it, what you'll find is that it seems to be the same basic themes that was involved in the traumatic event. And those tend to be related to power and control, so feeling like you don't have any trust, being able to trust other people, trust yourself to make judgments and decisions. It's related to safety, esteem, so how you feel about yourself and how you feel about other people, and then intimacy, being able to feel close to somebody else. When we asked veterans, they were much more likely to say that they were replicative. So the veterans were saying that they're dreaming about what they went through in combat over and over and over again. 30% were similar and 20% were unrelated. So why does that matter? Well, we also found out that the closer your nightmares are to what actually happened to you, the more distress you're going to feel. Okay? So it's not just that you're having the nightmares about what you went through, and that's going to be very distressing. This is a very busy slide. Basically, all I want you to look at is we compared people who had replicative nightmares, similar nightmares, and dissimilar nightmares on lots of different things, like how long they slept, how depressed they felt when they woke up. And basically, the highlighted areas, everything that's a different color from the other, is a statistically significant difference. And all this basically says is that the people who are having the replicative nightmares are doing much worse than people who have similar and people who have dissimilar nightmares. Okay. So if that wasn't bad enough, the story gets a little bit more convoluted because the nightmares and the sleep problems are related to psychopathology over and above post-traumatic stress disorder. So they're going to be related to lots of different challenges, kind of like that slide before with I had things flying in all over the place. If you're not sleeping, pretty much nothing works. And that's relationships, that's depression, that's work, that's everything. It makes everything that much more challenging. You know how you feel after a night of not getting great sleep. Everything is a little bit more challenging. You react to things differently. I know I get a little bit cranky, just a little bit, when I don't get enough sleep. So people may notice that I haven't slept well the night before. So not only that, but when you try to treat the problem, they're resistant. Nightmares and sleep problems are notoriously resistant to change. So when people, we have these fantastic treatments for post-traumatic stress disorder. We have cognitive processing therapy, we have prolonged exposure, we have cognitive behavioral approaches. But what we're finding is that sometimes they don't work for sleep and nightmares. So you can treat and deal with and overcome lots of other things, but you're still going to have those issues. Even with the medications, they don't seem to be responsive to medications. They may conk somebody out for a little while, but then the person is going to still awaken with nightmares. We even found, not we as in me, but we as in researchers, found that a particular medication, that it's a blood pressure medication actually, called prazosin, that was, it was discovered serendipitously that it also treated nightmares, which is great, but you have to take it for the rest of your life. If you miss a dose, you have what is called a rebound effect, which means the nightmares come back and they come back worse. So not an ideal situation at all. So what's going on here? Why is this such a big problem? Well, you have a traumatic event, and there are going to be people who are more susceptible for nightmares and sleep problems. If you have that, you're getting disrupted rapid eye movement sleep. You're not getting that memory consolidation. You're not getting the restorative functions of sleep. You're going to have sleep deprivation. The next day, you're going to be kind of a mess. You're going to be more aroused. You're going to be anxious. You're going to be depressed. You're going to be reactive to things. You're going to be irritable. That is going to lead into, throughout the day and at night, you're going to start worrying about having another nightmare, not being able to get sleep. You're going to actually do things to try to get yourself to sleep really fast, like taking medications, taking substances, drinking yourself into a stupor. I have people who will do things to avoid sleep as much as possible. So I have a woman who would be vacuuming at 4 o'clock in the morning and like cleaning her house because she was so terrified of trying to go to sleep. She would do that until she literally fell down. So you do all of these things, and actually all of these things, like the rest of this, increases the chance that you're going to have a nightmare. So it is just a vicious, vicious cycle. So one of the issues that we've run into is that people researchers, the public, clinicians have thought about sleep and nightmares as being secondary to everything else. So they're just symptoms of PTSD. But what we have found increasingly is that that's not the case, that these may actually be a primary problem that need a solution all on their own. How do we know this? Well, we know that sleep problems immediately in the aftermath of trauma is going to increase the risk that you will develop full-blown post-traumatic stress disorder. We know that if you treat PTSD, typically it has much less of an effect on sleep and nightmares than anything else. We also know, the good thing, is that if you treat sleep problems directly, that not only do you impact the sleep problems, but for some people, you get rid of the PTSD just by focusing on the sleep. You don't have to do anything else for the PTSD. Not for everybody, but for some people, and I'll show you more about that. So, wow, all of that was to say that's what we did. We came up with a treatment for sleep and nightmares. It's called exposure, relaxation, and rescripting therapy. That's just a very descriptive way of stating what it is all about. It is for specifically trauma-related nightmares. We've wanted to try it out with non-trauma-related nightmares, but we couldn't get enough people who didn't have a traumatic event, unfortunately. So we don't know if it works for people who don't have that. Now, unlike edema, the treatment did not emerge fully formed from my head. There were a lot of things that went into it before I got involved. There is a treatment that is very similar that is called imagery rehearsal therapy, and it has been tried out with these different groups. It seems to be less effective for veterans, and it seems to be less effective for people who have severe post-traumatic stress disorder. One of the reasons is because if you do imagery rehearsal therapy, you're not doing exposure to the nightmare itself, which may probably be a key. And we're not exactly sure about that, but we're getting close. The treatment actually started when I was on postdoc at the National Crime Victim Center. I treated a woman who came in who had PTSD, panic disorder, and major depression. She had been raped over the course of a summer by a family member, raped repeatedly, and ended up having a child from those events. And I saw her 3 years later, so she had been suffering very significantly for 3 years. We administered a treatment for the PTSD, and when we got done, she didn't have PTSD anymore, she didn't have depression anymore, and she didn't have panic anymore. But she still had nightmares and insomnia. And so I looked through the literature, and at that time, I found that there was a treatment for non-trauma nightmares, and there was this description of a treatment for veterans, but it wasn't an actual study where they tested it out. And so I took that, and I added in parts of the treatment that we had already done with her, and then I sprinkled some sleep hygiene and modification stuff on top, and came up with our treatment approach. So we have, and then we did it with her, and 3 weeks later, no more nightmares. Very, very exciting. So I left my postdoc and came to Tulsa, and I thought, that's really probably not even a thing. I'm a scientist, I'm very skeptical. 3 sessions, nightmares gone? I don't think so. So we decided to test it out. And before this, I had no interest in nightmares and sleep problems whatsoever. But I wanted to figure out what this thing was all about. So we did a case series over the course of a summer and found that it worked really well. And that gave us enough evidence that we applied for funding to do a clinical trial. And that's what we did. And I'll show you the results of that in a minute, but I have 5 minutes left, so I'm going to go quick. So the treatment, basically we do lots and lots of psychoeducation about nightmares and trauma and sleep and how all of those things work together. I think that this is incredibly, incredibly powerful. When you give people the tools to understand what it is that's happening to them, especially at night, when it seems like they have absolutely no control over anything, if you can help them understand what's going on, for some people that's all they need. That makes all the difference. We do a number of different relaxation exercises to try to reduce that level of cognitive and physiological arousal at night. We do a lot of education about sleep hygiene, and then we have them start changing sleep habits over time. Session 2, we do actual exposure to the nightmare, so we have them write out their nightmare, start to finish, and we have very specific guidelines for how they need to do this. We identify what themes may be going on within the nightmare, so power and control, trust, intimacy, safety, and esteem. And then we have them take that theme and rewrite the nightmare to address that theme. So if they are feeling particularly powerless in the nightmare, we have them rewrite it so that they are very powerful. We teach them some more relaxation through diaphragmatic breathing. We give lots and lots of homework. I'm a professor, it's a thing, it's what I do. Session 3 is assessing their progress, problem solving if things haven't changed or started to change by then, and then we help them learn how to do their breathing much more slowly. It's much more relaxing that way. That's it. Okay, we did make some modifications for veterans, and I'll talk to you about that in a minute. But basically, that's the treatment. It's really quick, and there you have it. So this is what we found. So for the first randomized clinical trial that we did, again, a very busy slide, but basically you see that we knocked out nightmares completely in 74% of our sample. We not everybody who comes into the trial has a PTSD diagnosis. We had 53% when they came in, 21% when we were done. In terms of everything else, frequency of nightmares in the week, nights with nightmares, severity of nightmares, PTSD symptoms overall, we cut it in half. 3 sessions, cut it in half, okay? So there really does seem to be something to addressing sleep and nightmares directly. So that was the first trial. We got very, very excited. The second trial, we decided to look at, so they're telling us that they're feeling better, but what about physiologically? Are they responding less to the stimulus? So we wanted to know, do we reduce their physical response to the nightmares? So basically, we set up a study in which we had them, we would play a script of their nightmares over headphones to them, and we would intermix it with other scripts that had nothing to do with that. And we would measure heart rate, we would measure facial muscle movements, so the left corrugator muscle, so this is when you're frowning, you look distressed, that's that muscle, and we measured the lateralis frontalis, so the muscles that go up when you're really scared, and skin conductance, that's a bad picture of a guy who's all sweaty. So we measured them, all of this, when they were listening to their nightmares and other scripts before we did treatment and then after we did treatment. And this is what we found on the psychological measures, that depression went down, PTSD symptoms went down, sleep quality problems went down, number of nightmares went down, nightmare severity totally bottomed out. So even if they were still having the nightmares, they were like, meh, yeah, had one of those again. Didn't bother. And this just shows you over time how everything seemed to decrease, number of nightmares. And then if you look at what we found with the physiological, so this is the corrugator muscle, and you see before treatment how they were responsive, and then after treatment how much it went down. This was the control group that didn't get any treatment, no change at all. And this was so that was to their nightmare script. This was to a general fear script. So we're not, and nothing changed here. So we're not changing how they respond in terms of their fear levels. We're changing how they're responding here, right? And we don't want to change people's response to fear stimuli. That's what keeps you alive. So that's a good thing. Lateralis frontalis, same exact pattern. Heart rate, same exact pattern. Skin conductance, same exact pattern. We made a difference physiologically as well as psychologically. When we looked at when these things happened, what we found is that everything here changed immediately. So 1 week after we treated them, this changed. When we looked at them 3 months later, these things were changing at that point. The things in pink are the ones that changed by 1 week but continued to change over time and continued to get much better. Our veteran study, this is, let's talk more about your defense mechanisms. And I put that on there to just indicate that veterans can be more challenging. There's a lot going on there, and it can be definitely more challenging. So things that work for other trauma populations may not work the same way for veterans. What we did is we added one more session. We modified the language so that it was veteran informed, and then we added a few more mindfulness exercises. And this is what we found, is that, again, we seem to be doing very well. So in terms of the number of nights that you have nightmares, in terms of the frequency of the nightmares themselves, and in terms of the severity, we still seem to be doing very well. So that was a 4-session treatment with our veterans. Very excited about this. And people have taken our treatment and they're starting to use it all over the country now. So this was a study that was done at the Houston VA. And again, they did a 6-session version of it, had great results. This was done in Ann Arbor, Michigan, where they took the nightmare treatment and they combined it with an insomnia treatment, and they had fantastic findings. This is our current study. So we are currently testing out 2 different versions of the nightmare treatment to see what might be more helpful. And this is the information that I have on the back of in the flyer in the back of the room. Bipolar, we have been excluding people who have bipolar, but we're starting a new trial where we're specifically looking, because the vast majority of calls that we get are people who have bipolar disorder, and so we want to see if we can help them. If you have somebody, a client, a friend, family member who you think might benefit, these are some numbers to call, and again, they're on the flyer in the back as well, and these are participants at follow-up.
Thank you, Dr. Davis.
Absolutely. But I'd be happy to answer any questions that people might have.
What a privilege to have her right in our midst and to have you come out